think we will come to the that one in the last. Now we will invite Dr. Kiran Gopalakrishnan from Trivandrum to talk about ROCK inhibitors.
I think the reason why Durasta has only one insertion in the package is because the FDA has approved it only for single use. In their trials, they noted that with multiple use, it was causing endothelial cell loss. So they found that with single dose application, more than 10% of endothelial loss was not noted in even one person, but with multiple doses, there was some percentage of patients who had more than 10% endothelial cell loss. That is why there is approval only for a single insertion, which means the effect is going to go out after about 3 months or so. So, I mean, after that you are back to putting drops. Thank you, Dr. Radha Ramanan. Let me talk to you about ROCK inhibitors. If the presentation has some weird animations, please forgive me. I converted this into PowerPoint only yesterday night. It was originally a keynote presentation. I have no financial interest in the products that I describe here. So if you look at the timeline of drugs, in 2000 you had brinzolamide, which is basically a cousin of dorzolamide, which came back in 1994. From 2000 to 2014, pretty much no new drug came up. They were all either rehashed versions of the old drugs, some like tafluprost, mostly others were fixed dose combinations. In 2014, we had the in Japanese approving ripasudil for use in glaucoma, and then netarsudil approval with US FDA came in 2017. Now these are drugs that essentially acts on the actin filaments. Now what happens is, if you see on the left hand side, you have the control eyes of actin filaments, which are very tightly compacted, very tightly organized in the trabecular meshwork and the Schlemm's canal, and when they are exposed to these ROCK inhibitors, they undergo a discompaction, they become more loosely arranged, and therefore this increases the permeability in the trabecular meshwork, and therefore by increasing the permeability in the trabecular meshwork, it is increasing the conventional outflow. And the other drug that increases conventional outflow really is pilocarpine, though it acts indirectly. It will basically contract the ciliary muscle and thereby increases the conventional outflow through the trabecular meshwork. That's why all the other drugs will either act on the uveoscleral outflow or at the inflow tract, aqueous humor, and you have this drug acting on the trabecular outflow. Of course, nitric oxide donors, latanoprosin butyrate, not available in India, will also do this action on the trabecular outflow. Now, netarsudil is also believed to have an extra mechanism of action in that it inhibits the norepinephrine transporter and theoretically should have some effect on decreasing the aqueous humor production as well. Now, these drugs, when they used as monotherapy, these are initial trial data where you find that with respect to control eyes, it's effective in reducing intraocular pressure, as you can see on the lower graph, line of the graph, and you find that they're effective even when the baseline is less than 21. And when they are added on to prostaglandin analogs, they do work in reducing the intraocular pressure an extra few millimeters. So does it work when it is added on to beta blockers, and then even when you add it to a combination of both prostaglandin and beta blockers. Now, if you are worried about hyperemia with prostaglandins, you should be more worried about hyperemia with this drug. On average, about 50 to 75% in multiple trial data with hyperemia, mostly classified as mild or moderate and sometimes transient. The major reasons in most studies which has led to discontinuation of the drug has not been hyperemia, but blepharitis and allergic conjunctivitis, which is again not surprising because usually added on as as an adjuvant. Now, an interesting thing that was noted in the initial publications was that even when a patient is already on 4 medications or even on 5 medications, addition of these ROCK kinase inhibitors generally, you see that weird animation? Not supposed to happen. So when you add this on patients who are already on these number of medications, in about 60% of patients, you can have a reduction of intraocular pressure even further by another 10%. So that is an interesting thing to note, because as you add on more and more medications, generally the effect comes down. But this drug, possibly because of acting on the trabecular outflow, which is untouched by the other drugs, might have an impact when others may not work. So this is to be kept in mind. And this was replicated even in the post-marketing surveillance study that was done, where they found that it is effective in all forms of glaucoma except neovascular glaucoma, but neovascular glaucoma basically nothing works. And in the exception of patients who are already on 5 or more medications, this was not effective, but up to 4, an addition of this drug did make an impact. I'm not saying that you should add this as the 5th medication, but certainly if you are already on, say, 2 or 3 medications and the patient's target intraocular pressure is not obtained, you can consider substituting one of them with this, and this might have an outsized effect compared to other drugs. Now, a thing that to be noted very, very clearly is that it is inferior to prostaglandin analogs in terms of intraocular pressure reduction. It's not a first-line drug. And the hyperemia is also, as I said, I mean, if you are concerned with latanoprost hyperemia, you can see the difference is almost 3 times. It's much, much higher. Now, a combination of both prostaglandin analog, that's latanoprost and netarsudil, is approved by the US FDA and is available in the US since 2019. It's probably going to come in India also soon, and they seem to also work, again, with the caveat that because of the addition of this drug along with the prostaglandin, you will have an outsized response to the conjunctival hyperemia, this thing. Now, of course, non-intraocular pressure effects of Rho kinase inhibitors. Every drug is touted to have some non-IOP mechanism. Just like every other drug in the market, it's also supposed to have some impact on the ocular blood flow, but again, its clinical implication is extremely unclear. And some in vitro studies show that there is some effect of axonal regeneration after injury. These are all animal studies based on crush injury models. But one impact that has translated from animal study to clinical use is the effect on the corneal endothelium. Now, this is not very surprising because all the isoenzymes of ROC are actually present in the corneal endothelium as well. So, if you have an impact of the drug on the trabecular measure, it will also have some impact on the corneal endothelium. Luckily, the impact is relatively positive, right? Just he mentioned about carbonic anhydrase enzymes. So, carbonic anhydrase isoenzymes are also present in the endothelium, and that effect is actually counterproductive, but this effect is good. So, initially, if you notice the central slide, a controlled surgical wound was created. This is a rabbit eye, and they found that addiction of this drug will cause the endothelium to proliferate and migrate and kind of close the wound. Now, this has now been utilized by our corneal colleagues quite a lot. They are using this in a lot of conditions with endothelial dysfunction. I'm just showing one example of a case series where they have tried this in a few case scenarios, all of which are associated with some degree of endothelial dysfunction, and an example where from a pentacam image of more than 700 microns, use of netarsudil once at night for a month has reduced the central corneal thickness by around about 100 microns. Now, however, there is always something, however, when you see something positive about any drug. As the corneal colleagues started using this more and more, then these reports started surfacing of a new entity which they called corneal honeycombing or reticular bullous epithelial edema. So essentially what you found was, if you took at the top picture, you had these discrete epithelial vesicles, as you can see on the KSOCT image, which happened in those patients who were treated with these ROC inhibitors for an endothelial stromal edema or endothelial dysfunction related stromal edema. And once you stop the drug, it generally disappeared. And the hypothesis at this point of time was because you added this drug on, the edema got shifted from the from the deeper stromal layers to the subepithelial layer. But a publication recently from India looked at this and found some interesting things, that this can occur even in the absence of pre-existing edema. So he did not have edema, but you need to have some kind of an endothelial compromise. And unlike earlier belief, this does affect visual acuity. Now, there is some differences between netarsudil and netarsudil as far as this honeycombing is concerned. With netarsudil, it is more frequent and the larger, and they are generally more widespread and will appear faster, on an average in about 25 days. But the time to disappearance is also faster with netarsudil once you withdraw the drug. So, take-home messages. They are inferior to prostaglandin analogs and should not be considered as a first line of drug. It has a unique mechanism in that it attacks the trabecular outflow and therefore can work even when other medications don't work. So it can be used as a substitute in certain conditions. And conjunctival hyperemia is very common. And as far as the non-IOP effects, it is very helpful in stromal corneal edema caused due to endothelial dysfunction, but you have to watch for epithelial edema or corneal honeycombing. Thank you.
Thank you, Dr.